data, as we can continue to sort of chip away at the arguments. As I say to my federal colleagues, they already pay for housing. It's called nursing homes. Yep.
Completely agree.
Yeah, about $6 billion are spent on nursing homes in the New York State Medicaid program, and it's impossible to argue that that's not what that is. So I think we just need to understand that there are other forms of housing that are far less expensive, that if we're creative and open-minded, we could, do a lot better by patients, consistent with Olmstead and consistent just generally with what's, what we really need to do to help individuals and patients.
Jenny, it'd be great if you could build on that. I see you nodding and talking about what the gaps are. Are they data? Are they legislative? And then I'll just throw out my own question before the audience. Donald Schwartz had shown us the chart of life expectancy and how when the bulk of the payments are during the last 6 months of life. And that's, as an insurance company, I'm sure, fairly shocking when you could try to move, how do you move that money earlier in the system?
Yeah, and it's interesting. I noted that when you said that it's deeper. The investments, yes. Programs have been structured around. Medicaid is a really good example with the waiver programs. The waivers wait until individuals are so sick that you can pretty much guarantee that they're going to be institutionalized. And I was fascinated about talking with a low-income housing developer in Kansas that they said the number one reason people get evicted that are elderly is because of incontinence. And for us to think about covering things like incontinence supplies earlier on in the progression of somebody's decline, it's a very cost-effective way to look at it. So I think to your point about the government side of it, part of what it is that we're looking for is kind of these, I don't want to say perfect opportunities, but ideal opportunities to look at aligning strategic capital with Medicaid services, with the capabilities that we have, and then bringing the right partners to the table, including the public housing authorities, including Medicaid programs, Medicaid directors, to start to engage in more innovative dialogue about how it is that we look to align these two worlds and then measure the outcomes over the long term. And I think advance that evidence that's so desperately needed. I don't think it's that, I can't speak on behalf of CMS, but I think that what we need to do is start to think more innovatively about how we're pushing that dialogue to understand if we're going to cover housing as a healthcare intervention, what does that mean? How long do we do it? Who do we do it for? And what are the expected cost savings that we see on the back end of it? The other thing I would say, too, about program design that I think is really important to be a part of the discussion is largely states, not all states, but a lot of states have really set up fragmented delivery systems. So they're going to have medical, they're going to have behavioral health sitting in another system, and bringing all of those things into one centralized system, whatever that system looks like, it's equally as important that those services are integrated in order for us to effectively support individuals and better manage the social determinants of health piece of it. So, and I had one other point. Oh, it's the incentives. I think we are at a point where there are incentives. It's a change in the discussion at the table with providers, with states, with managed care health plans. But there still are incentives that are not aligned. It's almost incentives to the point where they're no longer incentives. And I think in order for us to think about real system change, you have to align the incentives in an effective way to accomplish the change that you want to accomplish. So rate discussions with Medicaid managed care health plans, those type of things really kind of put this perverse incentive in the system to some degree, because when you better manage these things, you ratchet down utilization, you drive cost savings. We all are likely in the business, honestly, of putting ourselves out of business, right? That's what we want to do. But within doing that business, what you want to do is try to incentivize in a way that promotes the right kind of reform and then reinvest those savings in the right way back into the community. So I'll stop there.
I want to open it up to Q&A. If I seem nervous up here, it's because David set a very high bar, having 3 questions at once. I'm going to only be able to take one at a time.
Hi, I'm Kathy. I'm with CAV, Organizing Asian Communities, and we organize tenants in Chinatown and in Queensbridge public housing. So for us, a large majority of the housing stock is rent-stabilized housing, and there's a whole big push for building housing. and not so much of a conversation about preservation of housing. And so where we are, a lot of the tenants, I've had tenants who've been hospitalized because the landlord did a lockout on him. I have tenants who've had a stroke from all the tenant harassment. I think there's all these external pressures to flip these units to market rate. So, and I've been trying to make that connection to health and the health of our community, because in Chinatown there's a unit of like supermarkets and restaurants that they rely on. So I just challenge this thought about moving forward when we make these linkages to also think about the piece of preservation.
Thank you. There's not a question there, I don't think, right? So next.
I guess moving forward, how do we talk about preservation in these conversations about health and housing?
We've had this discussion internally, actually. So by way of background, we've been doing low-income housing tax credit investments since 2011. We've invested over $200 million. We've largely been doing that to some extent with our Treasury team makes those decisions, but we've largely been doing that in a silo. We haven't really looked at how are we using that capital in the most strategic fashion to better the community, to better the individuals that we serve, and to have that kind of, hopefully, tidal wave impact into the community. We're starting to have those conversations now about shifting how it is that we're using capital for exactly the preservation discussion. Be more thoughtful about how it is that we're doing that and investing that capital in ways that make sense to get in front of these trends that we see that are happening largely across the U.S.
And let me say something, because in Baltimore, we've been having this discussion because if you're familiar with Baltimore, there's the east side and the west side, and never the two shall meet. But on the east side, transformation, occurred because they displaced, some of the folks, not everybody, but it was a big transformation effort to change the face of the community. And so someone at one of the foundations said to me, well, there's more than one way to transform a community. You can do it with the people in place, or you can, lift them out and do it a different way. So what we've been trying to approach on the west side for these many years is with people in place. So how are they at the table involved in decision making? When there are resources that come into the community, how are they included? How are their voices actually heard? And I think that's really the biggest challenge, because after the unrest, there have been a lot of dollars that have come our way, and the community is still saying, how are we at the table when the decision is going to be made about improving the area that was impacted? Because if they're displaced and other things come in, gentrification, then it's the same pattern all over again. So that advocacy for being at the table, because someone said if you're not at the table, you're on the menu. The goal is to make sure their voices are heard.
Next question, please. Thank you.
This is a question for Jenny and Jason. I'm Tom Manning, an independent consultant. I'm working on a project where we're trying to keep people in housing. They're in affordable housing, living independently, but they are, some of them, trending towards having difficulty staying in their housing. We've reached out to a number of plans, Medicaid managed care plans, and largely their response has been, well, how many people is it that are in my plan? Not how many people are on Medicaid, how many are in my plan? And how long, and their second question is trying to figure out, it's not a question for me, it's a question to themselves, how long is this person going to be in my plan? And is it worth the investment? So, Jenny, I'm wondering, how did you make the decision to make that investment? And Jason, I'm wondering, as I see that, I see a Medicaid market that has fragmented itself, where you have clearly a large population that will, for long-term, be covered by Medicaid, but it's transferred that responsibility to companies that don't have that same long-term view.
So it's a great question. I think that part of what it is, how we're evaluating the investments that we're making, we're kind of looking at it two ways. One is the concentration question. How many individuals do we have within a complex? Because to some extent, we're trying to do this kind of work without adding costs back into the system. And so it really depends on the complex. I think the severity of the individuals that are within that complex. And I think to a large extent, the coverage that they have with us, it goes back to that waivers questions and what exactly it is that we're being reimbursed for under the Medicaid benefit structure for these individuals. So that is a piece of the discussion. Internally, we're trying to change that dialogue because to some extent, if we have 10 members there, it makes sense to make, disease management services and education seminars available to everyone in the complex. And so we're changing our thinking as it relates to that. The other piece I would say that we're looking at is how do we leverage our capabilities in kind of the core of what we do. We build networks, we try to create access to community-based services, and how do we do that in a way that allows us to get at kind of scattered site housing areas and concentration of bringing services maybe potentially into a zip code, and have those services trickle out into the community for our members and for our non-members too. I think to some extent, we as an organization are willing to consider the impact beyond those that are actually on our rolls.
Right. Also agree. It's an excellent question. I think the challenge we have is that in a multi-payer environment, and I think because of the Affordable Care Act and the way it's structured, we're going to remain in a multi-payer environment for the foreseeable future. The challenge any individual payer, insurance company, is going to face is individuals can change their plans annual basis usually. And so if I'm going to invest long term, what guarantee do I have that my investment is going to generate some return for me down the road? And that's a challenging environment for insurance companies to sort of process that information. I mean, I give you credit for beginning the discussion, but I would say, at least here in New York, one of our strategies is on the delivery system reform, is to try to, not within the context of Medicaid managed care, but what we're really trying to do is get providers to come together. We call them performing provider systems, but you can think of them as almost integrated delivery systems. But these are large groupings, hundreds if not thousands of providers. These are providers who are going to be in the community. They're based here. They're going to be there for long periods of time. So their time horizon is longer. Their concentration is greater. And they're going to be, under our waiver, under tremendous pressure to do something very specific, which is to reduce avoidable hospital use. And then they're going to be held accountable, and there's about $7.3 billion that's going to be flowing out to these organizations based on them actually achieving that result. So now I think that they are interested in starting to think about what housing could mean for them. I'm open to plan suggestions too in terms of how we can do it, but I think one of the challenges of the housing community, and this is what I've said to housing providers and developers, is that there a lot of cases, housing in the development of subsidized housing or supportive housing has been financed and driven to a great extent by the government. The government has been the sort of main sort of consumer, the main sort of catalyst. There have been developers who come up with very creative ideas, tax credits, different things, but it's really sort of the government that sort of intervenes, and I would say sort of the customer, quote unquote. And now what we're really saying is we want healthcare providers and potentially insurance companies to be customers. But in order to allow that customer to make the investment, the providers of those services need to start thinking a little more creatively about how you can offer that service in a way that providers and plans can sort of consume it and make targeted investments. Because in a lot of cases, they don't want to become, and they don't have the means to become, housing experts. And I'll give you an example of how this discussion is already happening. One of the performing provider systems in upstate, I was at a meeting, and a large group, diverse group of providers sitting around a table talking about housing as a problem. And one of the hospitals says, well, maybe we should just build some housing on our hospital campus. Not knowing at all that there are actually people who have expertise in this. There's things called tax credit programs to help finance it. There's this thing, Section 8, there's various options out there in the world that they might want to explore first before they start dumping a bunch of capital. model because they just have no experience, and they don't have the experience that at Bon Secours in Baltimore. So I think there's a growing interest out there as people begin to understand how challenging it is around some of these complex patients, and as we move to value-based payment, as providers are more and more on the hook for lowering those total cost of care for those people, I am optimistic that they will begin to see more and more the value of housing solutions. But that said, what I think would be a tremendous disservice and potentially a waste of money would be for them to sort of run off trying to solve this problem on their own, as opposed to integrating themselves with the array of individuals who have knowledge, expertise, and also bring money to the table. And that's what we have to sort of figure out. How do we engage that? But I think the good news, while we haven't figured it out, the good news is that the interest is growing.
Yeah. Well, and I think that just to build on your points, because I think they're excellent points, is that, and I think we've had this discussion internally as an organization, is it's not our core business to build buildings and to house our members. It just isn't. And so we wouldn't be good at it, to your point. And so I think it's part of, and just I can't agree with you more about looking to consume the services that are already available in the community. We have to find kind of those partnership opportunities and those innovative partners at the table to help us do exactly what it is that you're doing. And those are all excellent, great points.
We have time for a couple more questions, and I know there are a lot of hands up there, so we're going to have networking reception, and panelists will be available later too. Stuart?
Stuart Kaplan, Self-Help Community Services. We provide affordable housing and all kinds of community-based services, primarily for seniors. And looking at that first chart that we saw up there, which has that growing population of seniors, and why do you rob banks? Because that's where the money is. So there's lots of expense that we would like to try to demonstrate there are savings for, but by definition, low-income seniors are dual eligibles. And the issue, Jason, that you're pointing to with CMS and having access to that data and having them recognize the savings is a problem that we're having in New York State. They've somewhat dealt with it in Vermont, in Oregon, where they've done these studies with both Medicare and Medicaid data. But we've had a lot of trouble in New York having access to both sets of data so that we can demonstrate the savings to the PPSs, to the disrupts, to the managed care companies, et cetera, et cetera. And so I'm wondering how the state might be able to help us to conduct that demonstration program with access to the Medicare data.
Sure. No, excellent point. Dually eligible individuals, tremendous needs, very complex. If you go to almost any emergency room at 3 o'clock on a Friday afternoon in New York City, you walk through those emergency rooms, you will see, chances are, lots and lots of dually eligible individuals whose healthcare status is not what we would want, who lack the family supports, who lack the type of housing that's necessary for them to meet their healthcare needs. So it's a population that cries out for more comprehensive solutions, and historically Medicare and Medicaid not on the same page. But I would say here in New York, a couple of things. First and foremost, our demonstration, our Delivery System Reform Incentive Payment Program, DSRIP, includes the dually eligible individuals. So we will be providing out to providers data that shows both the Medicaid and the Medicare sides of the equation for dually eligible individuals, because they are held accountable for improving results for that population as well. That data we will actually pull into our Medicaid data warehouse, make that available to a broader array of stakeholders. I mean, obviously we have to comply with HIPAA and other things, but we are actually developing an online solution where people can actually go into the database itself, pull data, do their own analysis, assuming they have the authority to be able to access that data. But I do think you're right. We need to find a way not only access the data, but to get Medicare to systematically participate in initiatives in which we can actually capture and then reinvest that Medicare savings. Because a lot of the avoidable hospital use and other institutional services are funded by Medicare. And unless we have a way to capture that, we're going to be in trouble. Now, the good news is that we have submitted to CMS a white paper concept. It was at the request of Secretary Burwell to talk about how we could coordinate the move to value-based payments in New York between Medicaid and Medicare. And so we're hopeful that that will be well received, because I think that'll be really key, because there's a lot of savings to be had for the dually eligible population if we can just do a better job of providing the housing solutions they need.
I have time for one more question.
Hi, I'm Frank Lang. I'm with St. Nick's Alliance. The state Department of Health actually has two other housing programs. They're called Home Care and the Assisted Living Program. And two areas that we're finding, we're the nonprofit direct provider that deals with all the managed care people. And we're finding now that the increase in the worker rates, which we really support, is not being met with the increase in the rates that are reimbursed to the providers. And the regulations on the home care and the assisted living actually discourage our home clients from participating. And so I'm wondering, as part of the redesign, how we're addressing those things, because otherwise we have the housing. Not that I don't want more money for housing, okay? But to answer the question about preservation, we can't keep the people in our housing if we can only provide either nursing home or minimal.
Right. I think the point you're making is a broader point, which is just we're going through a tumultuous period here in New York with our home care providers, a number of things, including some new federal regulations regarding overtime that are creating some financial challenges for providers. I think it's, as I said recently at a meeting of home care agencies, is that we have to get through this tumultuous period. But I do think that the future is yours in the sense that the move to value-based payment, the focus that we're going to provide on the need for non-institutional services, the focus that we're going to provide on and the accountability that's being introduced around reductions of avoidable hospital use will make home care agencies very valuable partners, much more so than has been the case in the past. So I think that while we have some current challenges around that, we got to work through those. I think at the end of the day, it's a really bright future for the home care industry, and I think will play an even more important role than they play today in how healthcare is delivered in New York.
Let's thank the panel. Great work. Bring the other panel up. All right, Ingrid Gould. Ingrid Gould Ellen. How can I do that? Of all people, from the Furman Center, is our moderator. I'll let her introduce the rest of the panel.
Okay. Terrific. Well, I'm delighted to be here, and what a beautiful room, I must say. Really humbling to be in this room. And humbling to be in this audience, a terrific group, and we are going to try to really keep to our 30 minutes of discussion among the panels, because I know there's a lot of expertise out there in the audience too, so we'll try to leave 15 minutes for questions. As Don said when he started us off, and as was just this last panel reminded us, that I think he said between a third and a half of our healthcare dollars are spent on keeping people alive in their last 6 months of life, and most of those expenditures are on seniors. So there's a lot of opportunity for savings when we think about providing housing for seniors and healthy housing for seniors. And that's only going to grow more so as our population ages and lives longer. So we have a terrific panel to talk about sort of the challenges and opportunities in developing and financing healthy housing for seniors. You have their full bios in the panel, but let me just say I'm delighted to welcome Shalal Alatieh who's chair of the New York City Housing Authority, John Broderick, who's Senior Policy Analyst at Leading Edge, New York, and Sidel Nepper, who's founder and CEO of SKA Nepper. So I want to start by talking a little bit about the challenges involved in developing and financing healthy, affordable housing for seniors, and in what ways. It seems to me there's potentially sort of three ways that what makes for healthy housing for seniors might be different than what makes for healthy housing for the rest of the population. And one is that seniors may need housing with different physical characteristics and configurations. Second, seniors may need more, or at least a different set of services than other people. And finally, seniors are likely to have fixed and